Hello, I'm Dr. Grivas. I'm a medical oncologist at Seattle Cancer Care Alliance, associate professor at University of Washington and Fred Hutchinson Cancer Research Center. Of course, we are very interested in characterizing the genomic landscape and different alteration types in the neuroendocrine prostate cancer. So working with Foundation Medicine in this study, we looked at prostate cancers that have neuroendocrine phenotype and those without. And also we focus specifically in those with neuroendocrine prostate cancer and try to analyze the different genomic alterations and genomic landscape of this neuroendocrine prostate cancer phenotype. Specifically, we focus our attention on RB1, and RB1 is frequently mutated in cases of neuroendocrine prostate cancer. And in our study, 61%, about 2/3 of the neuroendocrine prostate carcinomas had RB1 mutation, and we tried to compare genomic alterations in these RB1 mutated with RB1 non-mutated phenotypes with neuroendocrine prostate cancer. The majority of samples overall in prostate cancer research come from primary tumors, and I think that's something we have to think about as an oncology community. Can we develop biorepositories and databases where we can have prospectively collected metastatic tissues? But that's something we have to work on. Overall, though, in our trials and our prostate cancer research, most of the tissues come from the primary prostate cancer tissue. And that's what I think needs to be done, looking more specifically at the different variations and the degree of differentiation within the neuroendocrine prostate cancer. At the University of Washington and Fred Hutch, we had significant interest in looking at that particular question with Pete Nelson and other colleagues, and we're actually looking at dissecting specifically different subpopulations of areas of the tumor in order to characterize them genomically. So in our study, we didn't go to that much detail, but we tried to compare, again, the different genomic alterations in patients with and without the RB1 mutations, and we saw some differences. For example, the genomic alterations in androgen receptor or PTEN, there are differences between the RB1 mutated and non-mutated. So I think that's reasonable, to take into account when we design trials in the future, when we think about neuroendocrine prostate cancer, and think about combinatorial strategies to try to take advantage of the different genomic alterations in RB1 mutated and non-mutated neuroendocrine prostate cancer. One of the drawbacks of the study is we did not have a lot of clinical data annotation to make different analyses to evaluate potential association between the genomic findings and the outcomes of the patients or response to different treatment. That's what is missing, and I think is the next step. After we have this descriptive analysis and we describe the genomic landscape in RB1 mutated and non-mutated, the next step is to look at clinical data annotation and look at potential prognostic and predictive biomarkers down the road. We see this, a finding of PD-L1 low expression in some of the cases. I think we don't know exactly what this means in terms of selection for treatment or prognostically, because we lack the clinical annotation. I think it merits some further investigation, but in my opinion, not only PD-L1. It has to be in the context of TMB. Very few prostate cancer cases have high tumor mutational burden, high TMB. Very few, but also in the context of PD-L1 expression, maybe some populations of patients who may benefit from checkpoint inhibitors. And that's something that is under investigation right now, because checkpoint inhibition is not a home run so far in prostate cancer, has not been, a really big winner. So we have to identify the patients who might benefit, and maybe those with high TMB or MSI high status may benefit from checkpoint inhibitors. So I think we have to look further in potential relationship. But as we saw in the study, the proportion of patients who have MSI high or high TMB is very, very low. So that's something we have challenge with, and we have to think about different avenues and maybe combination therapies to evaluate the potential role of immunotherapy in prostate cancer beyond Shipoliu-LT we have now, and hopefully in the future we may have more opportunities in identifying predictive biomarkers. We're hopefully getting there in the future, we're not there yet.